Hello everyone, and welcome to our module on chronic leukemias. By way of review, a leukemia is a malignant proliferation of white blood cells, and importantly, the cells appear in the blood, and this is in contrast to lymphomas. Lymphomas are also white blood cell malignancies. However, in a lymphoma, the white blood cells usually do not spill into the blood, so therefore the hallmark of a leukemia and what makes a disorder a leukemia is the presence of an increased number of white blood cells in the blood. Leukemias are classified by whether they derive from the myeloid cell lineage or the lymphoid cell lineage, and also by whether they are acute or chronic. In another module, I talked about acute leukemias. These are leukemias that have a rapid onset of symptoms and typically involve blasts, which are very immature precursor cells in the bone marrow. In this module, we'll talk about chronic leukemias. These are leukemias which have a slower onset of symptoms or sometimes no symptoms at all, and the malignant cells are not blasts. They're usually more mature white blood cells. The first chronic leukemia that we'll discuss is called chronic myeloid leukemia, and in order to understand this disorder, let's briefly review the normal development of cells of the myeloid lineage. So in the bone marrow, you can find myeloid progenitor cells, and these cells can develop into either red cells, granulocytes, or platelets. Now, myeloid progenitor cells can also develop into myeloblasts, and if a myeloblast becomes malignant, that leads to acute myeloid leukemia, which I discuss in another video. However, a myeloid progenitor cell can also become malignant in such a way that it overproduces red cells, granulocytes, or platelets, and when that happens, that leads to development of a myeloproliferative disorder. If the myeloid progenitor cell that becomes malignant overproduces red cells, that will lead to the disorder polycythemia vera. If the myeloid progenitor cell becomes malignant and overproduces platelets, that leads to essential thrombocytosis. If the myeloid progenitor cell becomes malignant and overproduces granulocytes, granulocytes are a type of white blood cell, and therefore this particular subtype of myeloproliferative disorder is a form of leukemia, and that's called chronic myeloid leukemia. It is a subtype of myeloproliferative disorders. So CML is chronic myeloid or chronic myelogenous leukemia. It is a malignant disorder of myeloid progenitor cells, and it leads to the dysregulated production of granulocytes. And recall that granulocytes are neutrophils, basophils, and eosinophils, so you're going to see increased numbers of these cells in the blood in patients who have CML. It can be classified as a leukemia because the disease results in an increased number of white blood cells in the bloodstream. However, it's also classified as a myeloproliferative disorder because, as I showed you on the last slide, it results in overproliferation of cells of the myeloid lineage. If you think of CML as a disorder with overproduction of granulocytes, then it's easy to understand the findings in the peripheral blood in patients in the chronic phase of this illness. First of all, there will be a leukocytosis. A normal white blood cell count is about 10,000, and the median white blood cell count in patients with CML is about 100,000. Importantly, you will see an increase in all cell types that are granulocytes, so you will see an increased number of neutrophils, basophils, and eosinophils. Recall that neutrophils develop through a number of stages, including myeloblasts and promyelocytes and myelocytes and metamyelocytes and bands. You will see an increase in all of these forms as well as an increase in mature neutrophils. Also notice that I've bolded the increase in basophils. It's very rare to see an increase in basophils. If you see a board question where a patient has an increased number of basophils, one of the things you should think about is CML. The other cell lines are minimally affected. There may be a mild anemia, there can be normal or increased platelets, but the predominant finding is an increase in cells of the granulocyte lineage, including all of the precursor forms of neutrophils. CML progresses through a number of phases. The first phase is called the chronic phase, which can last many years. This phase is often asymptomatic. Many times an increased white blood cell count is found on routine blood work, and that's how this leukemia is diagnosed. When patients do have symptoms, they're often nonspecific, including fatigue, malaise, and weight loss. Sometimes there is splenomegaly from white blood cell infiltration of the spleen. Importantly, the chronic phase has very few blasts. Usually less than 2% of cells are blasts in this phase. After several years, patients can enter what's called an accelerated phase, which usually lasts several months. This phase is characterized by treatment failure and a rising white blood cell count despite therapy. The accelerated phase can then progress to what's known as a blast crisis. This is where the chronic leukemia converts to an acute leukemia, and there are more than 20% blasts found in the peripheral blood smear or in the bone marrow. Usually the blasts are myeloblasts, and thus the blast crisis is a version of acute myelogenous leukemia. Less commonly, the blasts are lymphoblasts, and the patients develop an ALL. It's very important to distinguish chronic myelogenous leukemia from a left shift or a leukemoid reaction, which is a normal response to infection. When you suspect a patient of having CML, you have to rule out the possibility that they have an occult infection that is driving the production of granulocytes, because in the setting of infection, you also see an increase in the number of bands and neutrophils. So you have to distinguish this situation from CML in order to make the diagnosis of leukemia. In the table on the screen, I've shown you what happens to the white blood cell count in a patient who goes from a normal state to a state of infection. In the normal state, the white cells are about 10,000 with about 55% neutrophils and 5% bands. In the setting of infection, the white blood cell count rises and the percentage of neutrophils and bands also rises. This is not leukemia, so you have to exclude a left shift or leukemoid reaction. In other words, you have to exclude a reaction to infection in order to make the diagnosis of CML. One of the ways you can do this involves an enzyme called leukocyte alkaline phosphatase, or LAP. This is an enzyme found in normal neutrophils, and importantly, it's absent in the neutrophils of CML. So you can assess this enzyme level and determine something called an LAP score. If the LAP score is low, it suggests the patient has CML. If the LAP score is high, it suggests the patient has a leukemoid reaction to some infection. This used to be done very commonly. Now it's largely been replaced by testing for the presence of the Philadelphia chromosome. The Philadelphia chromosome is an abnormal chromosome that is created by a chromosomal translocation, and it is the genetic hallmark of CML. If a patient has the Philadelphia chromosome, then they have CML, they do not have a leukemoid reaction. This abnormal chromosome is created by a translocation between chromosomes 9 and 22. If you look at the drawing on the screen here, the red chromosome is chromosome 9 and the blue chromosome is chromosome 22. On chromosome 9 is the ABL gene, and on chromosome 22 is the BCR gene. A translocation creates an abnormal chromosome where BCR and ABL are right next to each other. That abnormal chromosome is called the Philadelphia chromosome, and it contains a BCR-ABL fusion gene. This fusion gene allows synthesis of a tyrosine kinase protein that is abnormal. Basically, this tyrosine kinase protein is constitutively active, and it allows white blood cells to avoid apoptosis. Therefore, they have a long cell life and they accumulate in the bloodstream, and that's what leads to this form of leukemia. Because CML involves the Philadelphia chromosome and overactivity of a tyrosine kinase enzyme, a number of drugs have been developed to treat CML that are tyrosine kinase inhibitors. These drugs go by names like imatinib and dasatinib and nilotinib. They're oral pills. They're not chemotherapy agents that patients receive via infusion. Patients take these every day for treatment of CML. These drugs came out when I was in medical school, and they were a breakthrough at the time. It was very unusual for patients to be able to take a pill every day to treat their leukemia. They're still used for the treatment of CML in the chronic phase. They provide long-term control of the disorder, but they're not curative. After many years of taking these drugs, the treatment eventually begins to fail, and that's when patients enter that accelerated phase I talked about before. At that point in time, patients are often offered a bone marrow transplant. Our next chronic leukemia is chronic lymphocytic leukemia. This is a malignancy of naive lymphocytes. They're not lymphoblasts. If you have a leukemia from lymphoblasts, that leads to an acute lymphoblastic leukemia. This is a disorder of naive lymphocytes that are newly produced by the bone marrow. The cells in CLL have a very characteristic immunophenotype, meaning they have very characteristic surface antigens. These cells are described as CD5 positive B cells. This is very unusual. CD5 is a T cell marker, but in the cells of CLL you find this T cell marker on B cells. The cells are sometimes described as co-expressing CD20 and CD5. They're described this way because CD20 is a typical B cell marker, but in the cells of CLL you find that typical B cell marker next to CD5, which is a typical T cell marker. I think of CLL as a confused malignancy because it's not sure whether it wants to be a leukemia or a lymphoma. The reason I think of it this way is because CLL is similar to a related lymphoma called small lymphocytic lymphoma. Both CLL and SLL have the same malignant cells. The disorders are differentiated clinically by the degree of lymphocytosis, meaning the degree of elevation of the white cell count. In CLL, it's a leukemia, so you have a high white blood cell count. In SLL, it's a lymphoma, so you will have swollen lymph nodes and a normal or mild lymphocytosis. The exact definition is that SLL is defined by a lymphocyte count of less than 5,000. CLL is defined as a lymphocyte count of greater than 5,000, but it is the same malignant cells in both disorders. CLL is a leukemia of older patients. The median age is about 60 years old, and most patients who have this leukemia are asymptomatic. It's usually picked up on routine blood work that shows an increased white blood cell count caused by increased numbers of lymphocytes. A small minority of patients, only about 5 to 10%, have B symptoms like fevers and sweats. Patients who have this leukemia can have swollen lymph nodes. They can also have splenomegaly and hepatomegaly. And if you remember that the malignant cells in SLL, which is a lymphoma, are the same malignant cells as in CLL, it's an easy way to remember that you may see lymphadenopathy in this disorder. And many patients who have this leukemia are observed without treatment. If the white blood cell count isn't that high, this condition is often not dangerous, and patients are simply monitored over time for changes in the white cell count. The hallmark of CLL in the peripheral smear is the presence of smudge cells. The peripheral lymphocytes in CLL are fragile and they're disrupted during preparation of the blood smear. Shown on the screen are a number of smudge cells. The lymphocytes don't look like this when they're circulating in the blood, but they take on this appearance when you prepare them for the blood smear. To understand the complications of CLL, you need to remember that it is a lymphocytic leukemia, and this means that lymphocytes are disrupted. One of the types of lymphocytes are the B cells, and B cells produce antibodies. So in CLL, you can see antibody abnormalities. Many patients develop hypogammaglobulinemia. This leads to low levels of IgG, IgA, and IgM, and clinically this leads to an increased susceptibility to bacterial infections. Patients with CLL can also develop autoantibodies. These are not produced by the malignant cells, they're produced by non-neoplastic cells that react to the leukemia. But one of the characteristic clinical consequences of this is that patients with CLL commonly develop an autoimmune hemolytic anemia. The feared complication of CLL also relates to disrupted B cells, and that complication is transformation into a diffuse large B cell lymphoma. The classic presentation of this CLL complication is for a patient to present who has known CLL and develops rapid growth of a single lymph node. That lymph node is not growing from the CLL, it's growing because the CLL has transformed into a diffuse large B cell lymphoma, and a biopsy needs to be performed and it will show presence of large B cell lymphoma cells. Our final chronic leukemia for this module is called hairy cell leukemia. It gets this name because of a characteristic appearance of the malignant cells on peripheral smear. This is a rare B cell malignancy. The malignant cells usually express B cell markers like CD19, CD20, and CD22. They also often express CD103. If you see expression of CD103 together with B cell markers, that's a very sensitive finding that's present in most cases of hairy cell leukemia. The hallmark on a peripheral smear is the presence of hairy cells. I've shown an example on the screen here. These are lymphocytes which have hair-like cytoplasmic projections, giving them the appearance of hairy cells. Hairy cell leukemia has a couple of unique features you need to be aware of, especially for step 1. The first is that this type of leukemia usually presents with massive splenomegaly. And the reason the spleen gets so big is because the red pulp gets engorged. The red pulp gets so large that there is atrophy or obliteration of the white pulp in many cases. We'll talk more about this in the next slide. Another unique feature is the presence of a dry tap on bone marrow biopsy. The hairy cells induce fibrosis, so when you attempt to do a bone marrow biopsy, you get what's known as a dry tap. And then the final unique feature has to do with an enzyme called tartrate-resistant acid phosphatase, or TRAP. This is a cellular enzyme, and hairy cells are characteristically strongly positive when you do TRAP staining. Here's a drawing of the spleen from our immunology modules, and the white pulp in the middle of the spleen is where you usually find white blood cells. What's unusual in hairy cell leukemia is that the white blood cells from the leukemia fill up the red pulp and engorge it to the point that it can almost obliterate the white pulp, and that's why the spleen gets so big in hairy cell leukemia. The median age at diagnosis for this leukemia is 52 years, and the presenting feature is often abdominal pain from a massively enlarged spleen. Patients can have nonspecific symptoms like fatigue or weakness, and splenomegaly is usually appreciated on physical exam. There may also be evidence of bone marrow suppression, including anemia and low platelets. This leukemia is highly treatable with a drug called cladribine. It's also called 2-chlorodeoxyadenosine, or 2-CDA. It's important for you to understand that years ago this leukemia was a death sentence. The mainstay of therapy was splenectomy, but even with that surgery, survival was only a couple of years. This changed when cladribine came to market, and because it has such a dramatic effect, it's something they're likely to ask you about on your boards. It's the preferred initial therapy for hairy cell leukemia. It produces an excellent clinical response. The drug has a similar chemical structure to the nucleotide adenosine, and adenosine is a purine, so cladribine is often called a purine analog. If you look at the bottom right side of the screen, this is the chemical structure of deoxyadenosine, which is used in DNA. Cladribine has almost the same structure, but for the addition of a chloride atom. It's taken up by the malignant cells in hairy cell leukemia, and it's highly toxic to the leukemic cells. And that concludes our module on chronic leukemia.